Assalamu alaikum. So thank you very much for the kind invitation and the kind introduction, Talat. It's a pleasure to be here. It's a pleasure to be with you for the first IBD conference for the Al Mubarak Al Kabir Hospital. It's also a pleasure for me, as Talat had said, I'm born here, so it's an emotional return back to where I was born. So it's a pleasure to be here back in Kuwait. So let's kickstart the morning. So I was asked by Talat to discuss a little bit refractory IBD patients, so what to do when standard therapy fails. This is my disclosure. So as you know, you've seen this slides multiple times. This is the standard therapy for IBD patients, where when we look at either Crohn's disease or ulcerative colitis, this is the normal pyramid of inflammatory diseases and the different treatment strategies that we have. And the higher up that we go on the strategy, the more close we get to surgery. And we know that our options of treatment have been limited over time, and I'll be talking about some new therapeutic options that you have for our refractory patients. So why do we need new therapy? Well, so far, most of our treatment has been limited up to anti-TNF treatment. But there is a need for newer therapeutic options. And one of the reasons for that is that if you look at the 6 months remission rates in patients with anti-TNF, you can see that the numbers are quite limited. So we have a good, at least 2/3 of our patients that were unable to put in clinical remission with anti-TNF treatment. Multiple therapeutic options have been tried in the past, and multiple of those has failed, as you can see. But one thing that is interesting is, if you look, this is the current pipeline of what is coming up on the market. It is very crowded, so there's a lot of therapeutic options that are coming on board. One thing that gastroenterologists, especially in IBD, have been good at doing is stealing ideas. We're very good at thefts, and most of the time we steal ideas from rheumatologists. So we see they're always ahead of us. They try medical treatment, some of their treatment, and then we say, oh, it works in rheumatology, let's try it in IBD, and often enough it works. So the first one here that I'll be talking to you about today is the selective anti-adhesion molecules. The selective anti-adhesion molecule is the first type of treatment that was not stolen from rheumatologists, because they're actually quite selective to the gut. But the idea was still stolen from neurologists. Okay, so we're still good at stealing ideas from other specialties. So it was recognized earlier on then that the migration of leukocytes plays an important role in inflammatory bowel disease, as you can see on this picture. When there's activation of inflammation, what happens are the T lymphocytes that are in the bloodstream will be, often enough, when there's activation, they'll be recruited into the lamina propria and then into the tissue of the gut through receptors, through adhesion receptors that we call, and this is what led to the production of the natalizumab and vedolizumab drugs that we'll be talking about. So this idea came on a long time ago, and natalizumab is a drug that was used in Crohn's disease for a while, but we had major limitations to that. So here again, so just to describe, so when we talked about these adhesion molecules, so the leukocyte comes, it has an alpha-4 beta-7 or an alpha-4 beta-1, so the natalizumab blocks the alpha-4 beta-1, and the vedolizumab blocks the alpha-4 beta-7. It binds to the MADCAM, and then it will be introduced into the tissue to cause active inflammation. So the first one that came, as I said, was many years ago, was natalizumab. And natalizumab was actually a very good drug for Crohn's disease, but the main issue with natalizumab was this here, which is the side effect profile. So most of us have the JC virus, which is a virus that lives in the kidney, in the interstitial tissue of the kidney. And 60% of adults have that virus present, and with the presence of natalizumab, then patients were developing what we call progressive multifocal leukoencephalopathy. So anything that looks a big name in neurology usually is a bad thing. So you don't want to have that. And these patients were dying on natalizumab. So it was stopped, and the treatment for Crohn's disease with natalizumab was halted because there was a big black box warning against that. So natalizumab blocks the alpha-4 beta-1, as we said, and alpha-4 beta-1 is present in the brain, and that's why it was causing the PML. However, if you look at vedolizumab, which is the most recent drug, so vedolizumab is actually a Canadian drug. It was first developed by Brian Fagan, and it was started over 15 years ago. And as you can see here, it does not change at all the CD count in patients, whether it's baseline or weeks later. So it does not act on the brain's barrier in terms of reducing the white cells. And if we look at the safety data that was published, this is a statistical analysis that can be done. It's called a Poisson analysis, where if you take the same number of patients that develop PML with natalizumab, we'd be expecting, with the number of exposed patients to vedolizumab today, we'd be expecting at least 12 cases to have developed PML, and we've seen 0 so far. So it is a safe drug up to now, and we don't see any signal of any PML with vedolizumab. So let's show you this. So vedolizumab was tried in both ulcerative colitis and Crohn's disease. So this is the first trial, the phase 3 trial that was done for ulcerative colitis. So patients were randomized to either vedolizumab 300 milligram every 4 weeks or every 8 weeks, or placebo. They were assessed at week 6, and then after that they were re-randomized into the maintenance group. And let me show you the results. So this is a patients in clinical response and remission rate. So at 6 weeks already, dividing patients exposed to anti-TNF versus non-exposed, so prior exposure versus naive to anti-TNF. And you can see that we have clinical responses of about 50% with remission rate 23% already at week 6. If you look at outcomes at week 52, again here we have, if you look at the mucosal healing rates, 56%, okay, which is quite good. No difference between the Q4 and Q8 dosing, so the 300 milligrams. Again, the same thing. This is a 52-week results, looking at either patients who were prior exposed to anti-TNF versus none. And in those studies, there were about 40% of patients that were exposed to anti-TNF. And you can see clearly that clinical remission rates were about 46 in patients that were exposed to anti-TNF. So this is a more difficult patient population that we're talking about, who failed anti-TNF treatment. And if they were not exposed to anti-TNF, we're talking about 60-65% remission rate, which are quite high for what treatments that we have so far. This is recent data that hasn't been published yet. It's about to be published anytime soon. And now we have data for up to 104 weeks of treatment on vedolizumab, and it shows us that if you reach remission, you'll stay in remission for a long period of time with remission rates of almost 80 to 90%, which is very good. So that was for clinical response, and clinical remission mirrors exactly the same thing. So we have between 70 and 80% maintenance of remission. So that was for ulcerative colitis. What about Crohn's disease? So vedolizumab was also studied for Crohn's disease. So same thing again. Same doses, 300 milligrams every 4 weeks or every 8 weeks versus placebo. Assessment was done at week 6 and then later on at week 52. So for Crohn's disease, the story is a little bit different. So when we looked at week 6, the clinical remission and response rate, you can see that the clinical remission was significant, but it was low at 14%. And in terms of response, there was no difference between vedolizumab and placebo. So at first we said, oh, maybe there's a problem there. Is it as good as we thought that it is in ulcerative colitis? Well, what you have to do is you probably have to wait a little bit longer, because 6 weeks is a bit too short for Crohn's disease because it's a transmural disease. So when you look at the data now at week 10, then there's a clear difference between vedolizumab group and the placebo group, where it is statistically significant with, as you see, response rates of almost 50%. Same thing, looking at 52 weeks, clinical remission rate of 36 with response rates of 45% and steroid-free remission of 30%. Okay, so again, very good results for Crohn's disease, but probably more longer term than short term. Same thing at 52 weeks here. We're looking at data with patients that were exposed to anti-TNF versus naive to anti-TNF. And you see that we always have the anti-TNF exposed patients are more difficult to treat. They're more, they usually have more severe disease, so the rates are usually lower, but still we're talking about 30 to 40% with, if you were exposed to anti-TNF, and close to 50 to 60% if you are not exposed to anti-TNF, which is very good for patients with Crohn's disease. Looking at the safety data, really no big signal. It looks like it's a very safe drug. No side effect profile that is different. The only small increased risk of infection is only in maybe for gastrointestinal conditions and maybe gastrointestinal infections, but it's only a trend. There's no real big flag there. Now, recently at the ACG in 2015, there were real-life data that started to come out. So there's a consortium in the United States looking at vedolizumab in real life. It's been there present for over a year. And you can see that for whether it's Crohn's disease or ulcerative colitis, there's a continuous increase in the risk and the rate of remissions or relapse and mucosal healing. And I'll show you some data here that is quite interesting. So if you look at the mucosal healing rates for patients with ulcerative colitis and Crohn's disease, so this is ulcerative colitis, this is Crohn's disease. You see at week 12, there's only 12% of ulcerative colitis patients versus 2% of Crohn's patients that were in mucosal healing. But when you reach week 30, which is 6 months, then you have 72% of patients that were in mucosal healing for ulcerative colitis and 20% for Crohn's disease. So it takes some time. It's an excellent remission. It's an excellent drug for maintenance. You might need to have something else that helps you during the induction, like such a steroid for the first maybe 3 months or so. Let's switch gear to ustekinumab. So back at stealing ideas from rheumatologists. So this is a drug that have been used for a while by rheumatologists and dermatologists as well. So ustekinumab is a blocker of the IL-12/23. So IL-12 and 23 they share a P40 subunit, and this ustekinumab blocks the P40 subunit for and hence blocking IL-12 and 23. So first, few case presentations where we had patients developing severe psoriatic arthritis and psoriatic dermatitis from anti-TNF treatment that were treated with ustekinumab, and they did quite well. And now we have initial data published in 2011. These are phase 2 data showing that remission rates were around 42%, which is quite good for Crohn's disease. And this is again another phase 2 trial. More recently, so right here at UEGW and the ACG as well, this is the UDT2 data that was presented. So UDT2 is the induction data for ustekinumab in Crohn's disease. So ustekinumab was given as placebo or 130 milligram single dose IV or 6 milligram per kilogram IV at start, and then 90 milligram for induction starting at week 8. So here we only have the induction data. So clinical response rates, so as you can see, no difference between the 130 milligram or the 6 milligram per kilo, but they're actually very good at 50 to 55% for ustekinumab for Crohn's patients. So these are very good results. And if you look at week 8, remission rates of around 40%. So there's a statistical significance that is better for the 6 milligram per kilo versus the 130 milligrams of ustekinumab. Again here, so these are reduction in the CRP, and as you can see, the 6 milligram per kilogram had a better reduction in CRP levels than the 130 milligram or the placebo, and that was statistically significant. In terms of safety, there's no signal. It's a quite safe drug. We have also a little bit of data from real life. So this, after the phase 2 trials, some of the real life data has been, people have been trying to use it, and it was used in the JETED group in France, and with a 65% clinical remission, which is quite good. And we also have at McGill, we have used it. We have we updated our data. We have over 100 patients that have been on ustekinumab for Crohn's disease, all of them refractory to anti-TNF. And Talat was involved in this publication as well. As you can see, at the end of the follow-up period, we have 71% of clinical response and 73% of steroid-free remission, which is quite interesting and quite impressive for a drug where patients have failed anti-TNF treatment. So again, this is from the same study, so dose of reduction of steroids and CRP reduction over time, consistent with the clinical remission. Very quickly, the last few slides. So on the near horizon, so we have few options that are coming up. So these two are quite interesting, and they're actually almost ready for prime time on the near future in the next few years. So other adhesion molecules. So there's etrolizumab and anti-MAdCAM. So this was presented in the Lancet in 2014. So interesting data at week 10 of 43% for etrolizumab. And anti-MAdCAM here again, also interesting result with significant improvement compared to placebo. And finally, the last ones we'll talk about are the signaling ones. So there's Mungerson and tofacitinib, which are two very interesting because they're oral drugs, and they're also a new option for Crohn's disease. So tofacitinib is a JAK1 and JAK3 blocker, which act in the signal pathway of inflammation. And this data was published in the New England Journal of Medicine showing, so these are 5 milligram BID, 10 milligram BID, or 15 milligram BID. And then, as you can see, will response almost 80%, and endoscopic remission of close to 80%. Now, in the most recent, this is a phase 2 trial. In the phase 3 trials, the 15 milligram per kilogram has been dropped out because of side effect profile. So we're using the 5 milligram or the 10 milligram, and we'll see the data coming up in a few years. But this is certainly a drug that you'll be using, and we have used it, and I have few experience with it, and we have actually very, very good results also. And it's very convenient because it's oral. Again, another thing that we stole from rheumatologists. The last one I'll talk about is the antisense or SMAD7 blocker. So SMAD7 is a gene that is expressed in active inflammation, and once you block the SMAD7, there's suppression of the inflammatory genes. So the Mungerson, which is an oral medication, antisense. So this is data that was presented also at DDW this past year, where you can see clearly that patients with clinical remission rates of, and this is a phase 2 trial, 75%, and anywhere between 60 to 70, 75% remission rates, which is quite interesting for an oral drug. This is only a phase 2, but it's quite promising. There's a phase 3 that is starting very shortly. So, quick summary. So we have limitation with our data, with the available treatment or armamentarium, of therapy for anti-TNF is limited to for IBD is limited to anti-TNF. So multiple new mechanisms that are that are present. So right now, so anti-integrins and anti-IL-12, vedolizumab for ulcerative colitis and Crohn's disease, ustekinumab for Crohn's disease only, and we have only the induction data. The maintenance data will be published next year, and then new therapeutic options are around the corner, the JAK inhibitors and the antisense. And I thank you for your attention.